and sewing it, and realized that what I was doing was completely futile. That we were going through motions, but this is done. He walked out of hospital 7 days later, went home, and I don't know what happened to him after that, but he certainly didn't die that day. On the opposite side of the intensive care unit, that very day was a 31-year-old young woman who had been previously completely healthy, came into the intensive care unit, went for an appendectomy and was having the appendix removed. And they're not entirely sure what happened. And at the end of the surgery, which took all of about 35 minutes, she did not wake up. We came to the intensive care unit, and then we did all sorts of things, medications, antibiotics, all sorts of things. And I was on call that night, so I looked after her that night in the intensive care unit, and by the following morning, 2 days after she had come into hospital, she was dead. And I realized that I was just as much at loss to explain why this 76-year-old young man walked out of hospital and this 32-year-old healthy woman died. And I was also very cognizant of the fact that I had very little to do with either outcome. And so one of the big things you realize when you deal with people, especially in surgery, because in surgery, especially cardiac surgery, you think about life and death all the time. Usually you think about the patient's death and your life after their death and all the trouble you will be in. But you think about life and death a lot, and you realize that we are all a spectrum. We're all potentially normal, and Dr. Aurora will tell you there's a whole host of definitions for what that means. But there's not one normal. And so if you study any kinds of statistics, they'll tell you about this thing called the normal distribution curve. It's a curve that if you're within the 96.5% in the middle, you're considered normal. I got that wrong. 95% that occurs in the middle. And there's 2.5% on this end and 2.5% of this end that are considered outside of the range of normal, and that would be considered abnormal. And in very different ways, these two patients, the 76-year-old and the 32-year-old, were hanging out in that 2.5% on opposite ends of the curves. And I realized the problem is not this 2.5%, it's the 95% in the middle, where we think that you have a medical problem, you come to see a doctor, we figure out what the problem is, we apply the therapy, and you get better. But that doesn't always work out. And so the problem is that most of us live in this 95%. We live in the middle where we think this is how this works all the time, and the inconvenient truths that exist at the ends we conveniently sweep under our mental rugs, and we don't think about them because they point out to us our inadequacies. Switching gears. About 6 months ago, I had the opportunity to talk to a family who had recently emigrated from Africa, and the child had a significant cardiac defect and they were going for surgery. And when I met them before the surgery to talk to them about what we were going to do and tell them about the risks and everything else, they insisted they'd bring with them their priest. Very, very religious Catholics, and they brought their priest with them. And the priest came to the meeting, so it was a very sort of awkward meeting for me, because I ended up speaking to the priest because he was the spokesperson for the family. I did not talk to the mother and father directly, I was speaking to the priest. But this is what they wanted, so we did this. And I soon realized that at some point we were going to have a bit of a confrontation. Because the priest insisted that with enough prayer, that everybody was praying, certainly the mother and father were praying daily, every minute. The whole congregation was praying for this child. And that they were convinced that there was going to be a miracle and the child was miraculously going to be cured of their cardiac condition and will not need surgery. And because of the risks, and really it was a very repairable cardiac condition, and I considered we would be able to repair this no problem. And it's what we would call a low-risk operation, which means there was less than about a 1.5% chance of the child not surviving the operation. Which, if it's not your child, doesn't really add up to very much. But there's no such thing as a low-risk heart operation for a parent. And so the priest, along with the consent of the parents, insisted that there was going to be a miraculous cure of the patient. And insisted that the day I was meeting them, which was the day before the surgery, that we should repeat an echocardiogram to look at the heart, because they were convinced that it had gotten better and disappeared. And so I proceeded over the next sort of 15 to 20 minutes in as kind a way as possible, and in a non-egotistical way as much as I could muster, to tell them that we were that miracle that they were praying for. That we would repair their child's heart, and unless we did that, it would not go away on its own, and that it was the very God that they were praying to that brought them here, so that the child could benefit from this miracle. And while you contemplate that, the third thing I will mention to you is, about 5 years ago, which is when I learned this, I had to take out, usually when you do heart surgery, there's some fluid and blood and so on that accumulates around the heart, and if it builds up around the heart, it doesn't do good things. So we put drainage tubes in that go around the heart. We do this while you're unconscious in the operating room, so it really doesn't matter to you. It matters a lot when you wake up, because you see this thing sticking up in the middle of your lower part of your chest and draining fluid with a little bit of blood in it, and as far as you're concerned, you're dying because you're bleeding out through the brain. And when that settles down, we remove the tube. And of course we do this now, you're awake, it's 2 days, 3 days later, and you're in the ICU, you're up on the floor or something. And it takes me all of 0.7 seconds to remove this tube. But you can imagine, if you're thinking about it, it would not occur to you that this would be a pleasant experience, nor would it occur to you that this would be a painless experience. And so for a little child, 3, 4, 5 years old, it doesn't matter to the baby, 6, 7 weeks old, they don't know enough to know about anything, so it doesn't figure into their thinking. But for the older children, this was a 5-year-old young girl, when I took it out, she was very upset, she was crying. And then the father looked at her and said, "Tell Dr. Maharaj, thank you." And it suddenly occurred to me, and I looked at her, I said, what in the world would she say thank you for? How many people here have had some sort of surgical procedure? It doesn't have to be anything major. 50, 60% of us. I'm sure there were many unpleasant things that happened to you during your stay in hospital. People taking your IVs, people sticking tubes into you, taking off dressings. If you ever want to be convinced of the theory of evolution, take a Band-Aid off. And you realize just how hairy we are. Excuse me. Usually, even to the point where people come to start intravenously in you, it's not a pleasant thing. Somebody comes and they take this big needle and they stick it across your skin into a vein. It doesn't take very long, but it's very unpleasant. You are smart enough to know that they need to put this intravenous in because they need to give you fluids, they need to give you medication, they need to give you all these things. And you understand that this is actually for your benefit. And so, very illogically, you lie there perfectly still and allow them to inflict pain on you. But for you, it's not pain, because you recognize that they're trying to help. Even when you have a resident, or God forbid a medical student come to do it, and it will take 4 or 5 attempts to do it. You will lie there and most of us won't complain very much. If you flip this over to a child, it does not matter what you do. And so what the children made me realize is that from their perspective, which is the only perspective that matters, all that ever happens to them in a hospital is people inflict pain and suffering on them. It is the parents who understand that you're trying to help them in a very meaningful way. And so for the adults, this is all okay. For the children, there's no different experience. The quick points to sum up are: there is no difference between religion, medicine, illness, pain, and suffering. They're all part of the spectrum of the continuum that we call life. The idea that there's a natural way of healing that is somehow separate from what we call Western medicine is really limited thinking. It is the manifestation of that Supreme, that Almighty, within the technology, within the teaching, within the surgeries, within the medicines, that allows the healing to happen. And healing only happens when you allow it to happen. All we do is assist the body to heal itself. And your belief that your body will heal is what actually allows it to heal. There was a report not too long ago of a place in the Middle East where people were having heart surgery, and they discovered, in fact, they weren't having any surgery. They were having their chest opened and closed and then being sent home. But they all got better. They all felt better. And they all had improved lives. And where is God in all of this? Well, they are where they always are. Everywhere, involved in everything. Thank you.
At each stage of life, very practical point. But before I do, I got this email from one of our devotees. This person has asked me that we should train our local Indian doctors about prayers while treating Hindu patients. That's the email. I'm curious why the Indian doctors and why the Hindu patients. Because what I'm going to say is applicable to everybody. And just bear with me. People are surprised that I'm part of the discussion here. Those who know me, I do not do conventional prayers. I never did, and probably will not do. So that is very clear. But I do prayers every day. Without fail, I do prayers. It may not be the same, which is conventionally, and I apply that principle to the patients. And I'll describe to you how I do it. No matter what subject you take, kidney, heart, anything for that matter, a group of doctors develop some guidelines. And after developing those guidelines, they treat patients. And I'm going to describe to you how those guidelines are developed. It is all based on evidence. It's all evidence-based, otherwise we will not come up with the guidelines. I just want to tell you. And what are these guidelines based on? Evidence. What causes the disease? How it progresses, and what are the treatment options? That's the gist of it. Now, as I say, it's applicable to all of us. And how I apply in my day-to-day life, I'll give you an example of a patient. A living patient, how I deal with that patient, using that information patient is referred to me with a kidney disease. So he comes, what I do, I take the history, physical examination, do certain tests, and then call the patient back. Second time. First time I spend exactly 1 hour with the patient. The second time in about 15 minutes. So when the patient comes second time, what's the first thing the patient asks? Do I have kidney disease? What caused it? Where do we go from here? And that's what I just said. What caused the disease, how it progresses, and that's what the patient is asking. And how do we answer that? What causes the disease, or what is the cause of the disease? Those who have been attending seminars here, they know the answer. In each one of us, if we develop health problems, there are only 2 reasons. There's no third reason. One reason is, it is beyond your control.
Genetics.
Nothing you can do. It's no fault of yours. And as a doctor, I can't do a thing. And that is what we call it non-modifiable. You can't do a thing. And it's related to genes, gender, ethnicity, and age. It is not theoretical. It is applicable to each patient. If you are really into it, then you have to use this information dealing with every patient. So that is one reason. What's the other reason? Second reason. Second reason is, you may laugh, the patient has not lived the life the way the patient should have lived, or lifestyle. Whose fault is it? The patient's. And can we do something? Yes, we can do that. And that is the second reason. Modifiable, lifestyle, the way you live your daily life. Have you heard the word, the way you live your daily life? That's what Hindu religion is. The way of life. I don't have to tell you, you know more than that. Way of life. How you live your daily life. And I discuss with each patient. Now, if the patient is not convinced with it, is a young person or whatever age group, then over time, there are warnings to the patient. You are not living the way you should live, and I'm giving you as a doctor warning. I'm looking for the warning signs. And that is my second question. Markers of the disease or mediators or warnings. That it is applicable to all of us. We live daily life the way you live, and over time, you may have what I'm going to list, put on a lot of weight, you develop diabetes, blood pressure, develop cholesterol problems, and very important, sedentary life, and the last one is your stress. We go through this from our younger age to the day we die. Certain lifestyle, good and bad, and the consequences of these markers. Each patient is explained. Now comes the third point. Which patient interested? Is there damage to the kidney? Yes. You start with the damage to the blood vessel first, and then the whole organ is damaged. Patient asks, where do we go from here? There are different stages of the disease. If it is a stage 1, you can help. If it is stage 5, you're finished. So people come at different stages, and that's what we offer. Either the patient has symptoms or not symptoms. The last thing, which is the most important, what do we do? And that's where the prayers come into. Let's take step by step. Treatment guidelines based on one cause, lifestyle. I put emphasis on lifestyle. Sit with the patient, get the dietitian, get the social worker. Basically, you're disciplining the patient. You must live the life the way you should be. Your way of life should be good. And this is the basic in the philosophy. So it comes very handy. 2, markers of the disease. We prescribe all kinds of medications listed there with all the pharmacists. Again, you need a discipline. Without that, you may be doing the same thing as you do with the lifestyle. Damage to the blood vessels and the organs, depending upon the stage, and we offer dialysis and transplant. There is no place here at this stage that my advice will work, because we have reached the stage beyond the point of return, stage 4, 5 of kidney disease. This is all what I've said to you, purely and simply based on one thing, and that is cell biology. Biological changes have taken place in the cell as a result, mostly, of your lifestyle. Genes, gender, all that stuff that I mentioned does have bearing, but small. Most of the time, it is your lifestyle, the way you live. Emphasis I put on a way of life. To me, that's the prayer, which I put so much emphasis, the way I live my daily life. And that is the prayer I do every day. I don't need a symbol. I don't need a priest. You heard from other speakers, you sit in a small right corner, quietly, what did I do whole day? That will give you what you want to know. And I pass it on to the patients without fail. Surinder, you mentioned, and here it is. I tell the patient, in no uncertain terms, that the problem with your body and mind, body, physical health, mental health, is an imbalance. Is an imbalance between what? Your mind and intellect. Your mind has taken over. You left your intellect behind, so you do what your mind tells you, and that is the root cause, if you look at it, biologically or otherwise, for our health issues. I do not bring God into it. Never. Our problems are due to us, and that is my question. Now, there are a lot of questions I'll ask Dr. Dehadia, Dr. Arora, Dr. Maharaj about the prayers, or anybody else for that matter. The role of prayer. What is prayer? You heard? Prayer. To who? Anybody outside of me? Or prayer to myself? I think you have to decide. You know what I'm talking about. And how? How do you do prayers? You make a symbol, you do prayers, you do donations, you do offerings, and on and on. Or there are other ways to do the prayers. And then you say, what is the expectation? What am I expecting by doing prayers? Will I cure my disease? Harsh talked about miracles, may. Don't expect the miracles, may happen, but that is not our way of looking at it. My expectation is that if the patient is following a proper lifestyle, then the cause that causing the kidney disease may be less. The risk factors or markers may come under better control. Symptoms may improve because now there is a lot more discipline. But will it change the basic disease in the blood vessel and the kidney? I'm afraid I don't accept this, short of miracles. So this is my last slide. What is prayer? And I open for discussion now, as time has come up. Any question? Dr. Raman. Dr. Raman, if you don't know, I have enormous respect for what he has done. He's an epidemiologist of known at the university. We look to epidemiologists for evidence, and he always asks me, where is the evidence? So any comment?
A simple anecdote. Go to the mic, oh, I should. Well, this is in particular reference to prayer, especially going to the temple. More than 40 years ago, an epoch-making paper was published in the American Journal of Epidemiology. They found that people who go to church have lower morbidity, live a longer life. And that was a very interesting paper. And I studied that paper. Fortunately, they had provided all the data that was used to arrive at that conclusion. So when I looked at the data, I found that the study focused on people based on their verbal evidence, but they have missed certain very important points. People who go to church generally are older. They are adjusted for sex, I mean age, no problem there. But they forgot that the people who go to church have a different lifestyle compared to the people who don't. And they totally ignored that issue. So I wrote a critique on that, not only myself, several other epidemiologists wrote on that. So, but still, the controversy remained. Future studies were done, and after 2000, a few more studies have come. And they have adjusted for these lifestyle factors. So now, doing a meta-analysis, the conclusion is that the effect is not significant. There is an effect, perhaps, it is. The sample size is not enough to say that it is significant. So whether prayer helps or not, or whether being religious helps or not, is a question which is still not answered. So I want to just say something about Kakapali and Nyaya, which Dr. Rader knows very well. So whether this is all